Good morning. Thank you. First of all, I want to thank Manus and Manus for inviting me to this course every year. It's getting better and better, and I enjoy being here. Thank you, Pericles, for starting this, but you ignored the stemless prosthesis got the longest follow-up on your presentation. But it's okay. I'm going to talk about it now. Yeah. Okay. So I'm going to talk about more than 13 years now of experience and results with the Verso stemless reverse metaphyseal prosthesis. I'd like to thank all my previous fellows. Some of them are sitting here in the audience, George Alice and Andreas Leonidou, that collected all the data over the years. This is my disclosure. I'm the designer of the prosthesis. So we know that reverse shoulder prostheses are gaining popularity in recent years, and we know that now in the US, the UK, Australia, Germany, Italy, there's more than 60% of shoulder replacement are reverse, and it's growing. I think in the last NGR, Australia was 73%. In France, I believe it's more than 80% as well. And we see that's growing. Now, just a little bit to talk about what is a stemmed, what is a short stem, and what is a stemless. So this is a stemmed prosthesis. This is a short stem prosthesis because it goes to the shaft, to the proximal diaphysis. And this is a stemless prosthesis. It doesn't go to the shaft at all. It's only metaphyseal. Now, we see more and more prostheses, but we have the high complication rate. We heard about it today. Although hopefully it's getting down and down, but as we get better surgeons and better implants, but still it's quite concerning. And more concerning than that is this significant reoperation rate has been described in the past by Pascal Boileau, about 22% in cuff tear arthropathy or up to 60% in revisions. And you can see at the bottom there in the graph, this is from Brad Edwards, only in 10 years, how many revisions of reverse prosthesis were done. And we all know that to remove a well-fixed stem, it's not an easy task. And we see recently, in recent years, we see more and more of these patients with revisions, with longer and longer stems and less bone stock. And the question is what to do next. And we see them, we see a lot of them, especially in big centers. We get them and what to do next. And then this is only the tip of the iceberg because we will see more and more of that because more of these implants are getting in. And we need to develop a different attitude, a different point of view. We have to think about the patient journey or the patient shoulder journey through life and plan the journey and preserve the bone and preserve the options for future revisions without jeopardizing the good results. So with that in mind, we designed the Verso, which is a triple-finned stemless metaphyseal reverse prosthesis. We have clinical experience since 2005, so it's more than 13 years now. And the design principles is to have a minimal bone resection, bone-preserving prosthesis. We have a stemless metaphyseal fixation, which is a cancellous fixation only in the cancellous bone, and the special shape of a triple-finned. And with bone impaction technique, we can implant it even in cases of osteoporosis, bone cyst, osteopenia, whatever. We are not concerned about it, and I'll show it to you later. So we do the bone graft impaction, and it's a total cancellous fixation. And you can see here, we use the head that we resected, and we impact the bone. If we don't have the head, it's in the case of revision, we can use bone graft substitute instead of that, and we do impaction. And you can see here, as we impact the bone, we will put some more and put the real implant in. And this is the real implant in. And the shape is important because it's a triple-finned shape that gives you very good stability. It's all hydroxyapatite coated. So you'll see now that if we try the stability after we've done that, it's a rock solid stable, and there's no need for a stem there. On the glenoid side, again, it's a tapered screw glenoid, and this gives us a very good fixation. At the bottom, you can see the graph from a study done by Imperial College in London. They compared 6 different prostheses, and you can see that the best came out as the Verso base plate with a micromotion of maximum micromotion of 48 microns, which is very good. And this allows us to use it even in severe bone loss without much of problem, as long as we can get fixation, good fixation to the sentinel screw, because we do not rely on the peripheral screws. They are only as anti-rotational screws. The prosthesis is very simple. We have to keep things simple, and this is I follow this principle from Leonardo da Vinci. Simplicity is the ultimate sophistication. Keep it simple. Less places for errors. Less places for mistakes. And what George actually mentioned earlier is the dialable liner. If you look at the bottom, by doing this oblique liner, we just reduce the impingement at the bottom, and actually we can dial the liner to every patient to have the best direction of version at the end version, even after we put the implant in. And we are actually, as George mentioned, we can actually test it preoperatively as well on a 3D computer system to assess that we have good rotational movements. So between 2005 and December 2011, so 5 to 12 years follow-up, we had 172 consecutive shoulders that underwent a reverse shoulder with a versus shoulder. 149 went with stemless metaphyseal implant, and 23 with stemmed implant. The stemmed implant used either in fractures or in revision cases. So actually you can see that there were 50 of them were operated as revision arthroplasty, 21 from stemmed implant to stemmed implant, and 29 to stemless, 3 of them from stemmed to stemless. Once you preserve the proximal metaphysis, you can do a stemless prosthesis. All the patients were assessed with a constant score, subjective shoulder value, satisfaction, radiological assessment, and video clips. I just want to ask your attention to put attention to the rotations of the patient I'm going to show as this lady or the lady or this lady. And this is, we can see the constant scores here that improved in all the different diagnoses. You can see she's got bilateral, and look at her rotations. I mean, elevation, you will see good elevations with any reverse shoulder, but look at the rotations. And we did a study on bilateral shoulder reverse shoulder replacement because there was a concern because of the rotation, and we couldn't find any problem with that. So the constant score improved from 15.6 to 59 at the last follow-up, with 86.8 the age and sex adjusted constant score overall. The range of movement, as you can see here, improved to an average of 130 degrees of elevation, 51 degrees of active external rotation, and 67 active internal rotation. And nearly most of the patients could actually easily use their arm to take care of their own hygiene with a hand behind the back. We have a very robust database, and this is from our database, and you can see that there were improvement in the constant score up to about 2 years. I mean, the most improvement was between 3 to 6 months, but this remained over the long term, and we didn't see any deterioration on the long term, the same as with the pain score and the range of movement. This is a bit more difficult group. This is the rheumatoid group, and you can see this gentleman here. He had a resurfacing on the left side, which I did some years before, and now he came with the rheumatoid on the right side. He was quite happy with the resurfacing, but no pain, but the function was reasonable for rheumatoid. And then I did a verso on one side, and then he came back and he said, "No, I want you to revise the other side as well." And this is 5.5 years after right verso and 2 years after revision of the left verso. And you can see that the results with the rheumatoids are very, very good. I mean, they're similar to the ones that are non-rheumatoids with this implant. We had some complications. We had 2 undisplaced fractures of the humeral metaphysis. This was early on, and I think this was when we impacted too much bone in a frail rheumatoid patients. Again, we treated it conservatively, put a PDS cord around the humerus and treated them a little bit slower with rehabilitation, and they all healed without any problems, no lucencies, no subsidence, nothing on the long term. 1 glenoid fracture, again, we used the screws to fix the glenoid base plate better and put some bone graft around, and then we had no problem with that. We had 3 early dislocations, again, 1 of them because the patient pushed himself out of the chair a week after surgery, and that's taught us in the early days to tell them not to do that. And there was this guy that was hinging out when he did external rotation. We had to go in, do a bit of release, remove the small osteophyte, and revise the liner. And this guy is 7 years down the line after this earlier revision without any problems. We had one glenosphere disengagement because of soft tissue interposition between the glenosphere and the base plate. Again, we learned from that. We added another step to the technique to make sure there's no soft tissue interposition. This lady, you can see the top, she had a fracture of the acromion, and this is the advantage of the NHS. This was the early days, and she was doing very well, and then she came in and she called. She said she has severe pain. She can't move her arm. So we brought her to the clinic. We saw the fracture of the acromion. Said, oh, we need to operate on that. Now, because of the NHS, she had to wait a month. When she came back for the pre-op assessment 2 weeks later, said, I'm fine, I'm fine. So this, we learned that for these fractures, we don't need to address them. The more difficult fractures are the spinal, the scapular spine fractures, which we had 6 of them. 3 I operated, 3 I treated conservatively, and the results are not great in either. I don't think that operating them is doing them any better. This is a more difficult thing to do. Glenoid fractures, I mean, this lady here fell down the stairs, and you see she fractured the glenoid. We revised her to, again, because of the fact that it's a central screw, it's very easy if you have enough, just if you have 12 millimeters of bone, you can do that. This is 3 years after revision and doing really, really well. Radiographically, we had no lucencies around the implants. There was no glenoid notching in 132 shoulders. We had about 20% of notching, mainly grade 1 and 2, and this appeared a bit later. And we had only 3.5% or 6 cases of grade 3 glenoid notching. And these were cases where we used initially a retentive liner, which is a deep liner, which I do not suggest to use anymore. This was in the early days. We were concerned about instability, and we learned over the years. Another problem that we see in recent years, and this has been described by Gilles Val's group and Luc Favre, is the stress shielding and the disappearance of the proximal humerus. And I was quite surprised to see that this happens again with a short stem implant. This is a paper by Tom Norris and his group showing, even with a Sendflex, a severe stress shielding of the proximal humerus in less than 2 years follow-up. And there are recent papers from Europe as well that supporting the same findings. We haven't seen that, and we have now more than 13 years. And I think it's because we have a different concept, because it's a cancellous fixation only, and I think the shape of the implant is really important. This is, what about young patients? We were talking about early this morning. This lady was the youngest patient that Steve Copeland did a resurfacing. He did a total resurfacing when she was 22 years old for juvenile rheumatoid arthritis. This is her 23 years later. And she lost the rotator cuff, as you can see. She's very limited, and she's only 45 years old. So I revised her to a verso. Now, this is her. She's 51 now, 6 years later. She's got the best range of movement she ever had. I don't know if this will last for the rest of her life, but I've got all the bone stock there, and if I need to do something else, I can do in the future. And this is the youngest patient I ever had. He's 33 years old. He's 12 years after a surfacing. He had a fracture, and he had it's the 5th operation that he had. And obviously the cuff is gone. He can't work. He can't do anything. Again, we revised him after long and hard talking with him about it. And this is him 2.5 years after surgery. He's now about 5 years after surgery. He's back to work, doing everything. Again, if it will not last for the rest of his life, we can do anything we want, because the bone stock is still there. And the patients are going back to all the sporting activities with not really a lot of problems. This is really encouraging. And I have some crazy guys that doing this. And this guy actually, when he's a revision from a stem to a stemless, and when one of the fellows actually saw that he says skydiving, he called me quickly in, and I went in, and the guy said, yes, Prof, I will do skydiving whether you allow me or not. I said, oh, give me some pictures. And he said, by the way, Professor, you actually improved my technique. I said, how come? He said, before that, I couldn't open my arm like that. I have to do this in order to jump. Now I can do it, I can fly. Okay, so I don't recommend it to all my patients. This is a special group of patients, a difficult group, and this is a study that George R. Alice did when he was my fellow, looking at the weight-bearing shoulders, patients with on wheelchairs, and we see the results are exactly the same as the normal population, but you have to be careful in the first 6 weeks. And just to show you a case, this is a 71-year-old lady with hemiplegia. She was 30 years, since the age of 30-something. She had a stroke. She's on a wheelchair. The only arm that worked was the left arm, but she developed now cuff arthropathy there, and she is in great deal of pain. Nobody wanted to touch her. I did it in Israel with one of my colleagues, and this is the lady 2.5 months later. I got it by Skype, this video, this is in the 2.5 months later. She's got full function, and she's very happy. You can see she's shouting, "Thank you, thank you." And the good results actually are supported by the good results with the tests, and as Pericles showed us. However, you have to be careful because there's a good results with the stemless. But if you read carefully the study by Philip Moroder, that I don't know if he's still here, they actually used the test as a stemless only in 18.4% of the cases, because they found that the bone was too soft to do that. And I don't know, we have one of the designers of the test here, Bruno, that can talk about it. But it's actually, most of the time they use it with a stem, because they weren't really happy with a bone stop. This is a case just to show you that the shape of the verso, with the verso, we have no problem. Look at this eggshell. There's no bone at all. When we cut it, it's a big cyst. And I used a bone graft substitute here, and you can see on the x-rays on the right there that it's incorporated. So again, you can say, oh, I could put a stem here. I could, yeah. But to show the point, if this works in this case, it works in any case. And another advantage of the stemless is this kind of fractures. The fractures are metaphyseal. And again, we had 8 cases of these fractures. Which one you would like to treat? The fracture on the right or the fracture on the left? It's a rhetoric question, of course. And this lady, actually, we treated 6 of them. We treated conservatively because it's metaphyseal fracture. It healed. She's got good function, not as good as she was before the fracture, but she's 88 and she can do that. And she's happy. She didn't have to have another operation. And only in 2 cases where she was fully displaced, we had to revise it to a stemmed implant. So there are limitations for use of stemless metaphyseal prosthesis: acute fractures, non-unions, severe bone loss, or when someone has been there with a stemmed implant before. And I put a question mark because sometimes if you preserve the bone, you can still do a stemless implant there. And for that, you need a stemmed implant, especially for these cases. And for fractures, as we talked earlier, for elderly patients, this is the treatment of choice of patients older than 70, 75, with 4-part fractures or fracture dislocations. They actually very quickly, within 3 months, they are functional and having good function. So to conclude, a stemless reverse shoulder gives an excellent long-term clinical and radiological results. It's a bone-preserving prosthesis. You can see that we get an outstanding range of movement, including external rotation and internal rotation, long survivorship, and no loosening or subsidence, and better revisability if this would be needed in the future. Thank you very much.